Good morning, respected faculty, my seniors, my co-residents. Today we are going to discuss about a very interesting case which presented to OPD. He is 49-year gentleman. He is a rickshaw driver and he belongs to lower middle class, and he is a resident of Haldwani in Uttarakhand. He presented with complaints of pain abdomen for 1.5 years and yellow discoloration of eyes for 7 days. And pain abdomen, it was in central abdomen and insidious in onset, gradually progressed, dull aching type, intermittent and radiating to back, and it aggravates on food intake, and it used to relieve on forward bending and oral analgesics. And there was a history of yellowish discoloration of eyes for last 7 days and not associated with any pruritus, and history of steatorrhea and loss of appetite were present. And there was no history of any vomiting, abdominal distension, melena, bleeding PR, loss of appetite, fever, no history of clay colored stools or dark colored urine. In the past, before 6 months, he had similar complaints, and he was admitted in the private hospital and he was managed conservatively. And at that time, he was diagnosed as chronic pancreatitis. And there was a history of diabetes for last 15 years, and he was on regular OHA. And no other comorbidities, no past surgical intervention, and there was no relevant family history, and he used to take mixed diet, and he is a chronic alcohol for last 10 years. He used to take 250 ml per day, and last alcohol intake was 2 months ago. And sleep was normal, and bowel habits are used to pass foul smelling stool that was sticky and floats on the water, and bladder habits are regular. He's on general examination. He's conscious, oriented, with full GCS. Vitals are stable, and BMI is 16 kg per meter square, and ECOG status 1. And there was a icterus, and no clubbing, no pedal edema, no cyanosis, no peripheral lymphadenopathy. On inspection, abdomen was scaphoid, all quadrants moving proportionately with respiration. There was no visible peristalsis, no visible lump, no scars. Hernial orifices and external genitalia are unremarkable. On superficial palpation, no local rise of temperature, no tenderness, no hepatomegaly, no splenomegaly. On deep palpation, there was a solitary oval lump of size around 5 into 3 centimeters. It was palpable on over epigastrium extending to right lumbar region. It was non-tender, hard in consistency, not moving with respiration. Margins were not well defined. There was no shifting dullness, and liver span was normal. And back and spine, there was no abnormality detected, and bowel sounds were normal. Left supraclavicular lymph node was negative. And on DRE, grade 2 prostatomegaly is there, and rest was normal. Other systemic examination was unremarkable. Summary: a 49-year-old gentleman, chronic alcoholic, presented with pain abdomen for 1.5 years in epigastric region and yellowish discoloration of eyes for 7 days, with history of steatorrhea and weight loss. And on examination, icterus was there, and on abdominal examination, solitary oval lump of size 5 to 3 centimeters palpable, which was non-tender, hard, and not moving with respiration. With this keeping in mind, our differential diagnosis was mass forming chronic pancreatitis with obstructive jaundice secondary to lower CBD stricture was my first DD. And as there was a lump and pain abdomen for 1.5 years with loss of appetite, carcinoma head of the pancreas also in my DDs, and next periampullary carcinoma. These were the investigations, and there was a total bilirubin was 8 and direct was 4.52, and ALP, GGT were raised, and HbA1c was 13 at the time, and tumor markers were within normal limit, CA19 and CEA. So patient was patient underwent a CMRI on OPD basis, and there was narrowing of distal CVD adjacent to pancreas that was query secondary to external compression of the pancreas with upstream dilatation with the diameter of 9.8 mm, and head and uncinate process of the pancreas appeared bulky at the time with 4.9 into 3.4 centimeters with the heterogeneous enhancement. MPD in this region was prominent with hypo-intense debris within, and the rest of the body and the tail of the pancreas appeared atrophic with the dilated MPD throughout of 2 centimeters. They have given impression in favor of chronic mass forming pancreatitis on MRI. On CT abdomen and thorax, Dr. Navin will discuss about CT findings.
Good morning everyone. CT, thorax and abdomen has been done for this patient, and these are the post-contrast abdominal images. In these images, we can see that the pancreas is atrophic and there is a gross dilatation of main pancreatic duct in its entire length, and a few dilated side branches are also seen in the pancreatic tail region. Multiple pancreatic calcifications are seen in the parenchyma and also in the pancreatic duct, and there is large calculus near the ampulla which is causing the gross upstream gross dilatation of the main pancreatic duct.
Use cursor.
This is the large calculi near the ampulla of Vetter, and this is causing the gross dilatation of the MPD upstream. Here this is the CBD which is dilated in its entire course with the narrowing in its distal part, that is the smooth narrowing in the distal part, suggestive of a likely due to stricture in the distal CBD. Upstream there is a bilobar IHBR is seen which is more on the left side as compared to the right side. These are the intrahepatic biliary radicals which are dilated on the left side also or on the right side also, but these are more prominent on the left side. Here this part is the head and the uncinate process of the pancreas, which is slightly bulky as compared to the, and some tissue is also there here in the pancreatic head region, and this is suspicious for the chronic mass forming pancreatitis. Rest of the abdomen is clear and there are no significant nodes in the retroperitoneum or also in the peripancreatic region, and there are no significant node in the mesentery. So summarizing this case, we have features of chronic pancreatitis with a mass in the head of the pancreas which is hypoenhancing, and there is dilatation of the CBD with mild narrowing in the distal part which is likely due to the stricture which could be formed due to the chronic inflammation of this chronic pancreatitis.
MRI?
Sir, we don't have MR images.
Why?
CD was damaged, sir, and departmental data was cleared.
In this image, is there any possibility of malignant lesion in the head of the pancreas? The rest of the things are inflammatory, that's fine. But what about the character of head of pancreas?
Few of the features such as there is smooth dilatation of MPD, and there is we are not able to see the MPD in the region of ampulla, like entering into the duodenum, but there is large calculus that can be due to that also. So these features suspicious for the malignancy, but rest of the things are more in favor of chronic calcific pancreatitis.
First is inflammatory.
First is inflammatory. Second,
there are possibility of malignancy
also.
even in this image.
Slightly not, but chronic pancreatitis will be more as in these images.
So that's
in the,
not because of chronic pancreatitis.
that could be, sir.
Can you show us the mass?
Sure.
So here somewhat this is bulky. The pancreatic head is bulky. This region.
Is this pancreatic protocol CT scan?
Yes, sir.
This is pancreatic protocol.
This is the venous field.
No, is this pancreatic protocol?
Yes.
Yes, sir.
On CT scan, many a times, the best of the radiologists cannot distinguish between the chronic pancreatitis, mass forming, and the malignancy. They are best distinguished by biopsy. So there are certain tumor markers which may help in differentiating to some extent, but the best differentiation is always done on table by either by intraoperative flow section study or by post-operative histopathological examination.
So what are the features which differentiate mass-forming pancreatitis from malignancy?
Sir, some signs has been described such as duct penetrating sign, that the duct which is narrowed in the segment of the mass which will travel through the mass, and it will not be completely obstructed by the mass lesion, and there will be smooth dilatation of the MPD. These signs are more in favor of the duct penetrating sign is more in favor of mass forming, and there is smooth dilatation and abrupt cutoff of duct. They are more in favor of malignancy.
With these investigations, a patient was provisionally diagnosed as chronic calcific pancreatitis with exocrine and endocrine insufficiency with EHBO, and he was admitted, and he was underwent ERCP with CVD stenting in the view of a distal CVD stricture on 24 June by medical gastroenterology department, and then he was taken transfer from a medical gastroenterology department in the view of further management for chronic pancreatitis. With pain, intractable pain as an indication, patient was planned for a brace procedure with Roux-en-Y hepatocogenostomy, and patient was optimized for surgery. In the view of uncontrolled diabetes, endocrinology opinion was taken and injectable insulin was started, and patient was optimized. Intraoperatively, we have found hard mass in the head and the uncinate process of pancreas, and it was closely abutting the portal vein, and there was no evidence of any metastatic disease in the peritoneal cavity, and the rest of the viscera were grossly normal. So we sent frozen from the hard mass. From the uncinate we took frozen and we sent it, and it came as negative initially, and then we opened the duct, and in duct we found mucinous tissue. Entire pancreatic duct we found the mucinous tissue, and with suspicion of malignancy again we sent the frozen of that mucinous tissue, which came as carcinoma. Then there was no any extension to the surrounding organs, and dense adhesions were present in the peripancreatic and pericholecystic pericholecal regions, and multiple pancreatic parenchymal and ductal calcifications were there. With the frozen biopsy, we have changed the plan to total pancreaticoduodenectomy with the splenectomy with Roux-en-Y hepatocogenostomy and gastrogenostomy with feeding genostomy. Because of the multifocality of the tumor, and there was an increased lymph nodal burden at the splenic hilum, and the splenic vessels was also tumor was abutting the splenic vessels, so we couldn't save them, so we did splenectomy also. And this was the intraoperative specimen with the growth in the head and uncinate process.
And you can show the entire pancreatic duct from head to uncinate to tail, that's dilated, grossly dilated. It's around 2.5 centimeters.
Yes. Postoperatively, patient was extubated on post-op day 1 and shifted to surgery ward, and there was no postoperative recovery was uneventful, and he was kept on endocrine and exocrine replacement, and vaccination was given at the time of the discharge, and he was discharged on post-op day 11. And on follow-up, patient was symptomatically better and accepting full oral diet. He is relieved of pain, and there were no fresh complaints. On histopathology report, it showed the poorly differentiated pancreatic ductal adenocarcinoma of head and body with areas of mucinous squamous differentiation. And total 52 lymph nodes were retrieved, and all are free of tumor with the pathological stage of PT3 N0 M0. Now Dr. Gajendra with histopathology.
Good morning everyone. I will be presenting the pathological part of this case. We received the requisition form from the Department of General Surgery with a provisional diagnosis of chronic calcific pancreatitis with mucinous cystic neoplasm of the pancreas. We received 2 containers for frozen section. Container 1 labeled as a biopsy from pancreatic head mass was negative for the malignancy, and second container labeled as pancreatic tissue from pancreatic duct showed the feature of carcinoma. After the frozen section, 7 more containers were received for histopathological examination, labeled as total pancreatico-duodenectomy with splenectomy, left gastric lymph node, retroportal lymph node, mucinous tissue, CHA lymph node, pancreatic head, and jejunal mesenteric lymph node. A specimen of pancreatico-duodenectomy. A specimen of total pancreatico-duodenectomy along with a splenectomy was sent. On serial slicing of pancreas, a grey-white solid cystic tumor identified in the head of pancreas measuring 6 into 5 into 4 centimeter. Similar tumor was identified in the body of pancreas measuring 2.5 into 2.5 into 2 centimeter. Other part of the this is the solid cystic. You can use this is the area of grey white to tan solid cystic tumor in the head of the pancreas, as well as also seen in the body of the pancreas. On microscopy, the tumor cell was arranged in solid pattern along with as well as in nest along with the desmoplastic stroma and mucin, focal area of calcification and areas of squamous differentiation. This photomicrograph shows multiple cystic species without lining epithelium and along with the desmoplastic stroma, ductal gland and nest of tumor cell floating in the mucin of cystic species. The diagnosis of mucinous cystic neoplasm, intraductal papillary mucinous neoplasm and serous cyst adenoma are ruled out as these cysts lacks the lining epithelium. This photomicrograph shows tumor cell arranged in solid as well as few in glands and areas of squamous differentiation comprising 20% of tumor area, which rule out the diagnosis of adenosquamous carcinoma. As for adenosquamous carcinoma, 30% of squamous differentiation is required. These squamous cells showed strong nuclear positivity 4p40. Adenocarcinoma is graded as grade 1 well differentiated, grade 2 moderately differentiated and grade 3 poorly differentiated on the basis of percentage of tumor arranged in the gland. As there is a tumor cell mainly arranged in the solid pattern and less than 50% in gland along with the desmoplastic stroma, ductal gland, mucins and squamous differentiation, the final diagnosis is given as a poorly differentiated pancreatic ductal adenocarcinoma with areas of mucinous and squamous differentiation. All the resected margin were free of tumor. A total of 52 lymph nodes were identified, which all were free of tumor. Spleen showed the feature of chronic venous congestion and was free of tumor. Gallbladder showed feature of chronic cholecystitis and was free of tumor. This is the representative photomicrograph for mucinous cystic neoplasm. In this photomicrograph, there is a cyst lined by a flat cuboidal to low columnar epithelium along with the stroma resembling the stroma of ovary. In figure 2, there is a cyst lined by intestinal type epithelium along with the tumor cell infiltrating into the underlying stroma, and hence it is a suggestive of mucinous cystic neoplasm with invasion. But in our case, the cyst lacks these epithelial lining.
So with this diagnosis, the further plan it was discussed with the medical oncology team, and he was started on chemotherapy. And systemic chemotherapy is used in all cases of pancreatic cancer, whether it is resectable, borderline, or unresectable, or metastatic. It can be used in all, and squamous and adeno-squamous differentiation, if it is there, it won't change the management. It is treated as a adenocarcinoma only. And SPAN4 trial showed when gemcitabine used along with the capecitabine, the outcome is good. So according to NCCN guidelines 2023, these two regimens were the category 1, and those are gemcitabine and capecitabine regimen and modified FOLFIRINOX. And we have started for this patient gemcitabine and capecitabine for 6 cycles. So mass forming chronic pancreatitis, we will be seeing this in 20 to 30% of cases of chronic pancreatitis. Here we have to differentiate it from the pancreatic carcinoma, because if we treat it as a mass forming chronic pancreatitis, if we delay the surgical management, then the patient will be having a poor bad prognosis, and there it is difficult to differentiate it with on radiology also. And few findings that could help to differentiate were duct penetrating sign, as Dr. Navin told, and in few literatures it was given in chronic pancreatitis there will be calcifications in the head of the pancreas, and when tumor starts to grow, those calcifications will go to the periphery of the tumor. So peripheral calcifications can be seen, and there won't be abrupt cutoff of the CBD in chronic pancreatitis, and it will be seen in the adenocarcinoma. And double duct sign occasionally present in the mass forming chronic pancreatitis. And tumor markers CA19-9 is not related to mass forming chronic pancreatitis, and it is elevated in the adenocarcinoma. And IgG4, it is elevated in the autoimmune chronic pancreatitis. And CA494 can be used. It has more sensitivity and specificity than CA99 in identifying adenocarcinoma. CA99 will be raised in other conditions also, which involving biliary tree and salivary glands. So it can be CA494 can be used. And on PET scan, based on the SUV uptake, there were pancreatic adenocarcinoma can be diagnosed. In diagnosing pancreatic cancer, CT, multidimensional CT will be the first investigation of choice. But the sensitivity and specificity of the CT in diagnosing the cancer is around 70 to 80%, and in less than 2 centimeters lesions, it is even less, around 50 to 55%. In those type of cases, endoscopic ultrasound will be helpful, and the advantage with the US is we can take FNAC also, or breast cytology, with this US. And is there any role of early surgery in chronic pancreatitis on the risk of pancreatic cancer? Evidence are saying yes, there is a role. In this, Raja Kalayarasan et al. He studied few meta-analysis. He took few articles which included the patients. They underwent drainage procedures and hybrid procedures for chronic pancreatitis, and he followed up those patients, and he followed up for incidence of pancreatic adenocarcinoma. In those patients, around 150 patients underwent surgical management chronic pancreatitis. In them, only 1% of the patient got pancreatic adenocarcinoma. Around 10% of the patients who didn't underwent surgical management got pancreatic adenocarcinoma. However, the drainage procedures or hybrid procedures for chronic pancreatitis, it won't affect the inflammatory process that is occurring in the pancreatitis. So further studies are needed whether impact of surgery is there or not. Thank you.